Assalamu alaikum. Now I would like to different endocrine pathological related disease starts with Carcinoid syndrome. This is the picture of the Carcinoid syndrome. This is prominent rosette. This is prominent rosette, especially metastatic small bowel lump. This is prominent rosette. This is Carcinoid syndrome. It's a tumor of the neuroendocrine cell. It's a tumor of neuroendocrine cell. What you have to remember is Carcinoid syndrome, that is wheezing, that is asthmatic wheezing, there is flushing and diarrhea. These three words, if you find that wheezing, flushing and diarrhea, if you found these three things, probably it is carcinoid. The carcinoid syndrome usually have the common location. It arises in intestine, small intestine, and in lung. It arises usually in the small intestine and lung. Okay, in carcinoid syndrome there is wheezing, flushing, diarrhea, but there is only right-sided valvular heart disease, not left-sided. Why? Right heart failure, right-sided valvular heart disease. There is right-sided valvular heart disease. The reason is the right-sided valvular heart disease because when the monoamine oxidase enzyme, that MAO, right-sided valvular heart disease, when monoamine oxidase enzyme passes through the right heart and it enters into the lung, in lung it causes enzymatic breakdown to 5-hydroxytryptamine before it goes to the left heart. With the help of these monoamine oxidase enzyme, because in lung there is presence of this enzyme causes breakdown of this tumor and convert into 5-hydroxytryptamine, and that's why it doesn't affect the left-sided heart, or it doesn't causes left-sided valvular heart disease. If you do lab, you will get increase 5-hydroxy indole acetic acid in urine. 5-hydroxy indole acetic acid in urine, and sometimes there is niacin deficiency, and sometimes there is niacin deficiency. Can you remember the niacin deficiency? The features of niacin deficiency. Niacin deficiency actually causes pellagra, and in there is diarrhea, dementia, and dermatitis. And if you think about the new tumor marker, the tumor marker is chromogranin A and synaptophysis. Tumor marker is a chromogranin A and synaptophysin. And as a treatment you should give octreotide, which is octreotide, which is somatostatin analog, and you can give telotristat. Telotristat for symptom control. And there is a rule of carcinoid syndrome that 1/3 is metastasized, 1/3 is multiple, and 1/3 present with second malignancy. And this is all about carcinoid syndrome. So in carcinoid syndrome You have to remember that using flushing diarrhea, there is increased 5-hydroxyindole acetic acid in urine. It doesn't affect the left side of the heart because monoamine enzymatic breakdown causes monoamine enzymatic breakdown happens in the lung because there is presence of MAO enzyme in the lung. That's why it doesn't affect the left side heart failure and the tumor marker. These are the things you have to remember in carcinoid syndrome. Now, pheochromocytoma. This is a picture of the pheochromocytoma. This is the tumor, the adrenal medulla. This is the tumor of the adrenal medulla. It's derived from chromaffin cell. It's derived from chromaffin cell. Chromaffin cell, and it's arising. It's a neural crest derivative. It's a neural crest derivative. These are the common thing usually we forget because we are very busy with the signs and symptoms and findings. We actually forgot this type of histology or embryology. We have to remember it. Now, all you have to remember that 5P, that is pain, that means episodic hypertension, that means headache. Pain, that means headache. Pressure, there is episodic hypertension, there is increased blood pressure. This is one of the important cause of hypertension, which is treatable. We know that hypertension are of two types: essential and non-essential. And essential is 95% is essential, which is idiopathic, and 5% has some causes. And if you correct the cause like this, if somebody has pheochromocytoma, if you remove the tumor, the hypertension is actually gone. Pain, pressure, there is palpitation, that means there is tachycardia, there is perspiration, there is excessive sweating, perspiration is sweating, and there is pallor. If you remember the 5P, you can easily say that the features of the pheochromocytoma, that pain, that means headache, pressure, that means increased blood pressure, palpitation, that means tachycardia, pallor, and perspiration. And if you talk about the etiology, it is 10%, rule of 10% malignant, bilateral, extra-adrenal, 10% extra-adrenal, usually happens in line of Zucker-Candle, organ of Zucker-Candle, and bladder wall. This is the area apart from adrenal gland. It usually occurs 10% calcify and 10% kids. Calcify and 10% for kids. And as a treatment, okay, before jumping into treatment, the labs, they are epinephrine and norepinephrine. Epinephrine is converted into metanephrine, and norepinephrine is converted into normetanephrine. And finally, it becomes VMA, vinyl mandelic acid. And in pheochromocytoma, you will get increased epinephrine and its metabolites like metanephrine, normetanephrine, and increased VMA. If you get increased urinary metanephrine and VMA, you can diagnose that this person might have pheochromocytoma. This person might have pheochromocytoma. If you think about germline mutation, it is associated with NF1, that means neurofibromatosis 1 It is associated with VHL, that means von Hippel-Lindau disease, and their other association is meant to be that means red mutation. That means red mutation NF1 VHL and red mutation. And as a treatment, you should, if you want to treat the patient, you have to give alpha blocker first, then you have to give beta blocker. When you are thinking that you will go to do surgery, you have to give alpha blocker, that means phenoxybenzamine, and then you have to give beta blocker, propranolol. Why? If you don't give alpha blocker, if you don't shut off the secretion of epinephrine and norepinephrine, if you do the surgery, there will be release of tons of epinephrine and norepinephrine that will causes hypertensive crisis. And that's why, to prevent hypertensive crisis, you have to give alpha blocker blocker, then you have to give beta blocker to before resecting the tumor. And this is a rule, and if you don't follow this rule, the patient might have hypertensive crisis. Now, insulinoma. Insulinoma is the tumor of the pancreatic beta cell. It's a beta cell tumor, and we know what beta cell does. Beta cell actually causes increased release of insulin. Okay, what happens in insulinoma? There is a triad called Whipple triad, not Whipple surgery. It's a Whipple triad. What does it mean? That means there is low blood glucose, there is symptoms of hypoglycemia, that means the patient may be lethargic, he might have syncope, diplopia, and symptoms really when you give glucose, and resolution of symptoms after normalization or resolution of symptoms after normalization of blood glucose. So what you have to remember, in Whipple triad there is low blood glucose, symptoms of hyperglycemia, and resolution of symptoms when you give patient resolution of symptoms of blood after normalization of the glucose level. In here, in lab, there is interesting thing. In lab, you have to remember there is increased insulin and increased C-peptide. Along with insulinoma, there are other conditions like sulfonylurea use, where there is increased insulin and increased C-peptide. There is increased insulin and increased C-peptide. In case of exogenous use, if you want to give exogenous, like if somebody is taking insulin exogenously, in that cases there is lack of C-peptide. You have to be clear in these circumstances. You have to clear in these circumstances. And there is association with MEN 1A syndrome. And treatment is surgical resection. In here, the treatment actually is surgical resection. If you do surgery, you can correct this tumor. Now leukogonoma. Leukogonoma is a tumor of the pancreatic alpha cell. It's an alpha cell tumor. In here, what you have to remember the 5D. That means in glucagonoma there is dermatitis, there is diabetes, there is DVT, there is declining weight, that means weight loss, there is depression. And for treating this tumor, you can give somatostatin analog called octreotide, and you can do surgery. So I am repeating it again that in glucagonoma there is diabetes, DVT, dermatitis, diabetes, DVT, dermatitis, declining weight, and depression. And as a treatment, you can give somatostatin analog octreotide for somatostatinoma. Somatostatinoma is the tumor of the pancreatic delta cell. What happens in somatostatinoma? Somatostatin actually inhibits everything. That means it inhibits secreting gastrin, cholecystokinin, everything. In the contrary, it only increases glucose. That's why there is increase there is glucose intolerance, and that means diabetes. There is diabetes, there is steatoria, there is diabetes, there is steatoria, there is gallstone, there is diabetes, there is steatoria, there is gallstone, and achlorohydria, there is achlorohydria. There is increasing glucose intolerance, steatoria, gallstone, achlorohydria, and for symptom control, you can give octreotide. Octreotide is preferable for symptom control. Now, Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is a tumor of our gastrin. It's a gastrin producing tumor. In Zollinger-Ellison syndrome, it is a gastrin producing tumor. So there is acid hypersecretion. Acid hypersecretion causes recurrent ulcer, causes recurrent acid hypersecretion causes recurrent ulcer in duodenum and jejunum. Recurrent ulcer in duodenum and jejunum. Acid hypersecretion causes recurrent ulcer in duodenum and jejunum. It presents with abdominal pain, diarrhea. The most important thing we have to remember that in lab there is positive secreting stimulation test. And what happens in secreting stimulation test? Normally if you give secretin, it will inhibit gastrin release. But in this case, as it is a disease, in spite of you giving this secretin, it doesn't reduce the gastrin level, and the gastrin level remains elevated even if you give the secretin. It is associated with MEN1A. And last thing I want to discuss about VIPoma. VIPoma. That means vasoactive intestinal peptide tumor of the vasoactive intestinal tumor. It's a rare neuroendocrine tumor, and in VIPoma, what you have to, it is also associated with MEN1A, And in here you have to remember this WDHA, that means watery diarrhea, hypokalemia, there is hypokalemia, and achlorhydria, there is achlorhydria. There is watery diarrhea, hypokalemia, and achlorhydria. Its primary symptom is secretory diarrhea, and it usually arises in pancreas. And this is all about lipoma. In this lecture, I have discussed about carcinoid syndrome, pheochromocytoma, and others endocrine pathologies. In short, it, most of them is taken from the book of first aid, and some of them is taken from the pathoma. Inshallah, you will be benefited because I try to say it in easiest manner, and I try to discuss it in the easiest manner. Inshallah, you will be benefited. And